Hi, everybody. Can everybody hear me okay? Yeah, everybody can hear? We're good? Great. If we could all just, other than myself, I'm hoping we could all stay muted until the end of the webinar, and then we're going to have a question and answer period. So we're going to get started just so I can keep on time for everything. So thanks for everybody for joining this webinar. We've got over 70 people registered, and I'm looking forward to sharing this information with you all. So, as many of you know, some of you are patients currently of mine. Some of you are patients that I've not yet met. My name's Dr. Erin Rurak. I'm a naturopathic doctor. I've been in practice for over 12 years. I have a fellowship in integrative oncology, and I'm also certified through the Menopause Society. And with those kind of designations, I've understandably focused in the topic of integrative cancer and women's health. And last year, in May of 2025, I opened Full Circle Integrative Health, which is a clinic just in North Burnaby. Ultimately, that was a decision I made primarily to be closer to my family. I live in East Vancouver, and I had been commuting to Fort Langley for over 11 years. And so what we'll cover today, this is our agenda. So we're going to start by talking about some modifiable cancer risk factors. And then we're going to move on to cancer screening. From there, we're going to be jumping into genetic testing and understanding our own risk of developing cancer. And then we'll have a questions and a discussion period at the end. So essentially, when it comes to cancer, it is something that I think there's a lot of wrong belief that it is thought to be primarily a genetic condition. And although genetics certainly do play a role in some individuals, many of the factors that lead to cancer are not genetic, but rather lifestyle factors. And so essentially, what we know is about 4 in every 10 cases of cancer can be prevented with changes in healthy lifestyle habits. And if we think about that in total, if we think about the number of people in the world that develop cancer, this could lessen the amount of deaths from cancers by about 3.3 million a year just by changing lifestyle habits. So it's a really important topic for us to have. And so here are some of essentially some cancers are more heavily linked to lifestyle factors than others. And so this is a table letting us know, well, what are the cancers that we know that have strong lifestyle risks, and what ones have moderate to strong. So certainly, as one could understand, lung cancer is one of the most preventable forms of cancer that people can develop. And then after that is colorectal cancer, endometrial, which is known as uterine cancer, liver cancer, and then moderately to strongly lifestyle linked is breast, esophageal. So that's essentially up in the esophagus, and pancreatic. How I see it, you can think of it, any cancer, anything that from our mouth all the way through our digestive tract, because of how we eat, all our food comes into contact with those cells. So any cancer from your mouth all the way down to your rectum, there's potential link to lifestyle factors in how we eat and drink that could impact the risk of those cancers. And so essentially, although there are a lot of these cancers that we know that have a lifestyle factor involved with them, interestingly, it can be quite overwhelming when we think, well, what causes what cancer with the lifestyle? But what we're going to realize is that there's a lot of overlapping factors that can cause a number of different cancers that we could adjust through how we live our life. And so when we look across these cancers that I had just discussed in the previous slide, there's patterns that develop. So if we just go back here quickly, we can even see this developing. So alcohol, metabolic health, weight, being sedentary. So of course, those things, if a person is in trying to improve their weight or trying to improve their nutrition, not only is it going to lower the risk for colon cancer, it could lower their risk for endometrial cancer as well as breast cancer. So just remember that. When you work towards reducing your risk of cancer through your lifestyle, you're not just reducing your risk of one cancer, but many cancers. And so what are some of these root drivers that through our lifestyle can trigger the growth of cancer? And so inflammation certainly is one of those factors. So people that carry more chronic inflammation, that can dysregulate our immune system. And understandably, with our nutrition, if there's any excess body weight, especially in the midsection, that type of midsection body weight, which is very common, understandably, for women to develop in menopause, that's known to cause inflammation as well as insulin resistance. And certainly toxins that we're exposed to through our foods, the air we breathe, smoking, secondhand smoke, those are well-known root drivers of cancer. Some of these things we can get away from. Some of them, unfortunately, we can't get away from. Lower activity, physical activity, and then certainly stress and lack of sleep play an integral role in cancer development. Essentially, stress is something that can suppress our immune systems. And our immune system, I would always think of our immune system as our natural surveyor in our system to recognize a virus in our body that shouldn't be there, a bacteria, or any of our own cells that go haywire. So anything that suppresses our immune system could therefore lead to an enhanced risk of cancer, and certainly stress and lack of sleep are examples of that. And so what we know here is that many of the different cancers that I brought up in the previous slide, they share underlying drivers to their development. And so then the question is, well, how can chronic inflammation, how can weight, how can these toxins and low physical activity, how does that lead to cancer? Like, what's the link there? And so if we think about that, essentially, if a person has chronic inflammation, if they have excess midsection weight and their insulin levels drive up, which then causes inflammation, then this can damage our DNA. And so, as I mentioned, sometimes people carry genetic risks for cancer, but sometimes people don't have any of these hereditary genetic mutations, but they just get their own mutations in their body that wasn't present when they were born, but developed as their body was aging. And so chronic inflammation is a great example of that. It can lead to mutations in our DNA, which can over time slowly change into cancer cells. And then as those cells get damaged, they don't, when cells are damaged, if they're healthy, they should die. It's called apoptosis. But if they're damaged in such a way that affects their ability to cell arrest, then they keep on growing and they start to look very differently than what they did when they were healthy. And that's essentially what leads to cancer. And then, of course, as I mentioned, our immune system should recognize these cells before they have the ability to develop into a full cancer. But if our immune system is suppressed, well, then you can think of that as our police force. And if it's not working well, then cancer can thrive. And then over time, this leads to the development of tumors. And so this should also let us know is that cancer does not develop overnight. This takes years and years and years to develop. And so if we talk about specific risk factors, we'll talk about lifestyle risk factors, body weight. And so body weight does matter, and it's becoming understandably increasingly more difficult to maintain healthy body weights in our society because we have so much quick availability to ultra processed and packaged foods, which, are highly convenient. They are often less money than whole foods. So there's different factors that can lead to people veering into more of the processed food department of eating. And unfortunately, that can understandably affect our overall weight. And so the cancers that are most affected by excess weight, breast. Breast, interestingly, weight only plays a role in breast cancer when women transition into postmenopause. So this is not a factor for premenopausal women, but it becomes a factor for women once they're postmenopausal. That excess weight after menopause becomes a risk for breast cancer. And we're not sure why that is only, or why it only happens for women when they're menopausal, but it's thought that maybe the midsection weight might increase the amount of estrogen present within the body. It can increase insulin resistance, which increases inflammation. So there's a number of different factors that may be involved that we don't fully understand. And then colorectal cancer is much higher likely to occur for people that have higher weight, and endometrial cancer is well known for this. And this is likely linked to higher circulating estrogen for women who have excess body fat. Some types of fat can produce estrogen. So if there's more fat on a body, then there could be more estrogen. And uterine cancer, by and large, thrives when there's extra estrogen floating around, and pancreatic cancer. And so, one would think that when we have this fat on our body and we feel it and we just like, it's just there, it's just hanging out, it's not doing anything, but it's making us uncomfortable. Well, it's doing quite a bit actually. It's far from inactive, our fat tissue. So, fat tissue can lead to inflammation in our body. We want the least amount of inflammation in our body as present as possible. And fat tissue tends to create a wonderful environment for inflammation to develop. That inflammation causes stress on our cells, which then causes wear and tear as they develop. And as I'd mentioned previously, that excess weight can, especially for women in their midsection, can really impact hormonal levels. And hormones essentially are a growth signal for some cancers. And the higher the blood sugars go, the higher the insulin goes. Insulin is supposed to drive our sugars in our blood into our cells, but if the sugar is too high for too long, insulin will get higher and higher and higher, and that creates a very strong growth medium for abnormal cells. And so when our bodies are not healthy metabolically, we're more developed to develop this insulin resistance. Then our insulin levels grow up. Many people have no awareness of this because rarely, certainly conventionally, insulin is rarely checked. And so high insulin could be going on in the background of somebody's body, even though their blood sugars look good. And it's not until usually years down the road that the blood sugars go up. If their insulin was checked 3 or 5 years before that, they could have been aware of an insulin level rising before their blood sugars started to rise. And it's easier to correct that sooner than later. I check a lot of people's insulin levels these days because I'm so mindful of that. And that high insulin then leads to growth factors and signals. And then oh, sorry, went the wrong way. And then if we compare that to a healthy metabolism, if we are not having excess fat on our body, typically our insulin level stays nice and healthy, and then we have more controlled growth within our body. And so essentially what we know there is that that high insulin creates an environment where cells are more likely to grow and less likely to die when they should. And one treatment that can be used off-labelly for many cancers that has shown some promise is metformin. So that's the medication that's used historically to treat type 2 diabetes, even for some people who have healthy blood sugars. But if they have certain types of cancers, adding metformin to their regime can actually lower the likelihood of that cancer coming back or growing. And so, of course, this should all let us know that it is important from time to time to have the insulin levels checked. This is rarely a covered test. It's something that patients often will have to pay out of pocket for. I think it's around $30. It's well worth it, in my opinion. And so if we think about, well, nutritionally, what could we do to better lessen our inflammation in our body, then I think number one is that we veer away from processed foods, ultra processed food, refined sugar, and focus on whole foods, foods that we know are natural to what we are supposed to eat. So our vegetables, our fruit, our meat from plant-based protein, lean meat, chicken, turkey, fish. Some red meat, if it's well raised, is great too. Um, and then, of course, there's not a one size fits all for nutrition. This is why it's so hard to study. Um, and so, how I see it is that what works well for someone's metabolism may not work well for another. And so it's not something that we can say every person should do this. It's a matter of understanding your body, understanding what nutrition seems to work best for your body, understanding if you have any food sensitivities that you carry through your system. And then we try to lessen those foods that don't work well for you and promote and include the foods that do. But on a global scale, the foods that work well for many people are foods that are whole foods. And that's your plants, that's your vegetables, fish, healthy fats from avocado, healthy omegas from your fattier fish, such as salmon and mackerel. Those are all really great options. Lots of veggies for your fiber. These foods tend to reduce inflammation. Fiber is well known to help balance our blood sugars, lessen insulin resistance, help with our satiety. So I'm a huge proponent of higher fiber diets, 30 to 40 grams a day. With that less inflammation, we don't have the same abnormal growth of cells going on in the background, which is what we're hoping for. And then the other thing to take into mind is everybody's at a different place in their life and with their health. And understandably, for some people, making any major nutritional adjustments can seem overwhelming and just perhaps not feasibly feasible. And so another way to look at nutrition is, you know, not always focusing just about what you're eating, but how much. Even if you don't change what you eat, but how much, lessening how much you eat can really make a difference in terms of how your insulin levels are created and produced through your pancreas and what your blood sugars are doing. And in our society, especially in our developed areas of the world, we have a significant issue with overnutrition where we simply just eat too much. We have so much access to food. A lot of that food, as I mentioned, is processed and unhealthy. So people just end to eat up way too much calories than they really should be doing. And this often happens unintentionally. I see it a lot in my practice where people don't understand why they're having trouble with their weight, as they feel they are eating healthy, and a lot of times they may be, but then when I ask them to track their calories for 2 weeks, don't change anything about what they're eating. We're just trying to get an understanding of what is happening. Is this an issue with something, you know, that they're consuming, or is there something not balanced in their body? Often what I see is people come back and we talk about what that tracking look like, and they're eating far more calories and carbohydrates and sugars and saturated fats than they had thought that they had. So that's really something that can be taken into consideration. And so if we are constantly just munching throughout the day, aimlessly, not hungry, but just out of boredom and not really thinking about it, then we're constantly exposing ourselves to energy to grow. And that's completely fine in some respects if you are using that energy. So if you're a high level athlete and you're constantly burning it, but the reality is a lot of people, including myself, you know, we're sitting at a desk for 8 hours a day and we're not, you're using it. And so this is where I think it's always reasonable if one of the most important things that if people are interested in understanding what is happening with their weight and it's not making sense, just before you start taking something, before you eliminate something, be it a food, be it a supplement, be it a medication, just track your nutrition using an app such as Chronometer or MyFitnessPal to see what you're actually putting into your body. And so vitamin D and cancer. So vitamin D, we can think of that. We get that from our sun when it's present. We know that vitamin D has an important part for our bone health, but it does so much more than that. Vitamin D plays an integral role in our immune system. And so just as I said, our immune system is our natural surveyor for our own cells that go haywire. So if our vitamin D is low, that can then impact our immune system so it's not working as well. And then that can, over time, a low vitamin D could drive the growth of cancer because our immune system is suppressed. So breast cancers that are well known to be linked to low circulating levels of vitamin D include, but are not limited. These are the big ones that we know: breast, colorectal, as well as prostate cancer. And essentially, where we live in British Columbia, uh, I would almost guarantee that if people are not taking vitamin D and they're staying in BC throughout the year and they get their vitamin D level checked, it will be deficient, especially if they get it checked in the winter. So it's a very common deficiency where we live because of our lack of sun throughout the year. And so vitamin D, helps control how cells grow, encourages damaged cells to die. It can reduce inflammation. And so certainly have your vitamin D levels checked yearly. Exercise is really important as well. As humans, we were never meant to be sedentary. We were meant to be active, searching for food, finding warm places to live, and running away from predators. So this whole sedentary life that we are now living is really not meant to be, but it is. And we know that regular exercise doesn't likely, in fact, play as strong a role as what we eat in cancer prevention, but it's still really important. So it could lower cancer risk by 10 to 25%. Very good evidence for breast, colon, and endometrial cancers. And of course, as I mentioned, if one thing to lower insulin is burning off sugar as a form of energy. So exercise works well for that. And it's not just running, it's not just biking, resistant training, lifting weights, Pilates, and yoga are all really great options too. We know that smoking has quite a strong influence with cancer. It's actually the leading preventable cause of cancer. And it's not just people smoking themselves, it's the exposure of smoke to people around them as well. And so understandably, lung highly linked to that. Bladder cancer. Bladder is one of those cancers that it's just an excretory organ. So if you're smoking and you have all those toxins running through your system, it's going to come out your urine in some shape or form. So that makes sense. And cervical, head and neck. Cervical for women, if women carry HPV and they smoke, so they have two risk factors, it increases their risk of cervical cancer by 66%. Huge increase. Go back the other way. And so, but then at the same time, when I was talking about low vitamin D, I was saying we don't get enough sun, but then on the other side, well, if you get too much sun, you're going to increase your risk of cancer. So it's kind of this balance. And so certainly we know that sun exposure is linked to all different forms of skin cancer, squamous cell, basal cell carcinoma, and the most concerning skin cancer being melanoma. And the effects of sunburn start in childhood. So if a child gets a terrible burn, at the age of 10, one might think, well, they're young, it's going to be okay. But that can actually change DNA then that can impact their risk when they're 60. So this really should start for kids right from the get-go. And that's important for parents to know. And so when it comes to UV exposure, so those are essentially the rays that affect our skin and lead to burns. There's two main ones that we should be aware of. The UVB, which is the UV exposure that is most linked to sunburns is also the most linked to skin cancer. So in our um, sunscreens, we have actually really good coverage in North America for preventing sunburns caused by UVB. Um, Whereas there's another, whoops, I keep doing that. There's another one, UVA, that penetrates deeper into the skin and it's more linked to aging. So for people who are trying to minimize fine lines, for example, so it's well known to cause wrinkles and just skin laxity, but there's also some skin cancer risk with UVA exposure. And interestingly, in North America, we have terrible coverage in our sunscreens for UVA, and it's a constant issue. There's a major push right now to get the Tinosorb approved by the FDA. The reason why we have issues in North America with getting Tinosorb approved to cover UVA exposure is because in North America, anything that is in a sunscreen that helps with preventing sunburns is considered a drug, and it takes forever to get approved. So we don't have very much. There's one, I think it's avobenzone, which is in UVA that can help with within our sunscreens for UVA exposure, but that's it. But in Europe, in Australia, in Japan, they have sunscreens that contain the Tinosorb, so it's completely fine to use in those parts of the world. So, you know, if I have a family member traveling to London, I always ask them to bring me back those types of sunscreens so that I can use them. And it's always something that you, if you're traveling to any of those countries, you could do the same, or if you have friends traveling. And of course, fair skinned individuals are at the highest risk because they have less melanin in their, which is a skin pigment that protects us naturally from these UV rays. And so alcohol and cancer, so it's a well-established carcinogen. There's no consensus on what the safe limits of alcohol for cancer are, so the less the better. And it's linked to really any cancer along from our mouth all the way down to our rectum. There's a strong link there. Breast cancer, liver, of course, because it has to metabolize alcohol. And there really is no risk-free amount, but it does increase exponentially the more you consume of it. And so if we think about why alcohol increases the risk, it's because of the carcinogen within it, acetaldehyde. And so what that is, it's a breakdown product of alcohol. The liver makes it, and that is a carcinogen. So it's just floating around our system, potentially leading to DNA damage. And so understandably, the more carcinogen that is floating around a system, the more likely over time that will cause cancer. And everybody's metabolism of alcohol through the liver is different. So you'll hear many people that drank heavily until they were 80 and they never developed any issue, whereas some people might develop liver cancer at the age of 60 because of their alcohol. It just shows how we are different in our ability to metabolize this carcinogen. Okay. And so I would always suggest getting liver enzymes checked annually and more frequently if you're a regular drinker. The other thing that alcohol can do is it can increase liver enzymes, leading to fatty liver disease, which is a silent epidemic in our developed countries. Essentially, fat can deposit in our liver, which then over time negatively impacts how our liver can process toxins and so forth. And then sometimes our liver enzymes start to climb. It is completely reversible with nutrition. And so, but it's just people don't get their liver enzymes checked and don't even know that they have this. And sometimes they'll get their liver enzymes checked. I see this quite frequently. They come back high and they're told it's nothing to worry about. We don't care unless the liver enzymes are threefold higher than the normal. Well, no, any increase in liver enzyme, in my opinion, should be treated then and not wait till it gets threefold higher, because by the time it gets that high, there's significant damage to the liver. It's going to take longer to heal. So essentially, when it comes to the lifestyle aspect of this webinar, we should really understand is that cancer does not develop overnight, and neither does the changes that we decide to make in our life to help lessen our cancer through lifestyle. Even small changes month to month will gradually add up and significantly lower one's risk of cancer throughout time. There doesn't need to be a change of 180 degrees in a month. If as long as you're feeling like you're going in the right direction with your nutrition, with your exercise, with your sleep and stress, you're likely going in the right direction with cancer and its prevention. So then I must say that when I started this talk, I said 4 in every 10 cancers are preventable through lifestyle. What that means is that approximately 6 in every 10 cancers are not, from what we know now, but I'm almost certain that over time we'll learn more and more about things that through our environment are increasing our cancer risk, and we'll find that over time more and more becomes preventable and less become unpreventable. But what this means is that still to this day, a lot of the cancers that develop, we don't know why, and we don't think it's because anything caused that in that person's environment or lifestyle. And that's especially true in my practice because the vast majority of people that I see are healthy people to begin with. They're just trying to understandably be more proactive with their health. And when I see them and they have developed cancer, I often try to figure out, well, what could have caused this? And a lot of the time I can't figure out because there's nothing in their lifestyle or blood work that seems off. And so I must stress that not all cancers are preventable. It could be, as I mentioned, genetics. There could be random cellular mutations. There could be environmental exposures that we are being currently exposed to that we have not yet linked to cancer. And so the list goes on and on. And so the risk is never zero, but so we must know that. So let's move on to screening. So now this is a time to reflect on, just to ask a question. So how many different cancers do you think the human body could develop? Do you think it's 50? Do you think it's 70? Do you think it's 150? Do you think it's 1,000? And the answer is it's well above 200. So there are so many different possible cancers that we as humans could develop. And then the question is, well, how many cancers do we currently have screening for? And it's 4. So screening is important because the purpose of screening is to try to catch cancer when it's early in its growth, where it's still local. Because if we can catch it when it's early and people don't have symptoms, then it's pretty much most of the time fully curable, and individuals don't necessarily have to go on to systemic treatments of chemo or radiation and so forth. So screening plays an important role because, as I mentioned, we try everything that we can do to the best of our capacity to be healthy. But even if we do that, we can still develop cancer. So if we develop cancer, we then try to catch it as early as possible so that it doesn't cause us long-term issues. So of the 4 things that we have screening for, my thought on this is, well, we might as well take advantage of what screening we do have because we certainly don't have very much of it. So let's talk about where our screening is. And so we have breast cancer screening. Certainly we do. So essentially for breast cancer screening, it's mammograms. This is the standard screening method for breast health. Is it perfect? Absolutely not. But it seems to be the best at this time that we have for a global population perspective. It's the only screening for breasts tissue that has shown to save lives. So I should also say that. And so women who are average risk should start their breast screening at the age of 40, and it's done every other year, really up into the age until I think people should know that the risk of breast cancer increases with age. So it doesn't make sense for me to suggest that people shouldn't get screening after the age of 75 if they're healthy, because it increases as people get older. So you just keep on your screening for as long as you can. And then, if there's somebody who's quite elderly who has other chronic health conditions that are likely going to lessen their lifespan to a year or so, then of course, maybe screening is not as necessary in an instance like that. And then it's self-refer. So anybody who's within this age bracket, if you're due, can just go and scan this QR code and you get to go to the BC Cancer Screening for site. And then certainly for women who have higher risk, then the screening changes. It often ends up being earlier, and different screening methods above and beyond mammograms can be used. What's interesting is there's quite a large increase in breast cancer development in women aged less than 40. So the concern is, well, women that develop breast cancer in their 20s and 30s often have a more aggressive form that is hard to pick up, and certainly very hard to pick up if the screening doesn't start until the age of 40. So that's a predicament at this point. I always think it's reasonable for women to know their breast health and know what feels normal and what doesn't. And if something doesn't feel normal, then don't just assume it's okay, even if you're in your 30s, because it should be assessed for you. But then the question is, well, how do you really know if you're high risk or not? And we're going to end with that with this presentation. So one thing that I think all women should know is they should know their breast density. And this is you can only figure this out on a mammogram. So I have women that come in and I'll ask them about their breast density, and they'll say, oh, I have breast dense and dense breast tissue. I'll ask them, well, how do you know that? And then they'll say, I can feel it. Well, and I have to let them know you can't feel that. It's a radiological finding, and it's only something that can be picked up on a mammogram. And so breast density can range from very low density, which is A, fatty, and then all the way up to pretty much all dense breast tissue, which is D. And so there's a star here, and that's to mimic a breast cancer as to what would show up on a mammogram. And so when women have very low breast density, such as this here, which is primarily made up of fatty breast tissue, mammograms worked so well at finding it, because fatty breast tissue shows up as gray and breast lesion shows up as white. And very true for women with B density. There's a little bit of density in there with the white. You can see that's the density part of the breast, but most of it's fatty and gray, and you can still see. Now we jump to the C. 40% of women have the density of C, and 10% of women have the density of D. You can see it's harder and harder to see that star, and it's no different than when women have a mammogram and they have dense breast tissue, and it's just as hard for a radiologist to find this in dense breast tissue it is for us looking at these images. Breast lesion shows up as white on a mammogram, but dense breast tissue shows up as white. So as I say it, it's like trying to find a snowball in a snowstorm. It becomes very difficult. And so if you find that you have a density of a C or a D, I would always suggest that you speak to your provider about what potential supplemental breast screening may be warranted, be it an ultrasound, be it an MRI, be it a 3D mammogram. It's known as a breast tomosynthesis, just so we don't miss anything for you. It takes Usually when women have these C or D density breast tissues, they will have a mammogram done. It'll come back negative, so no cancer, even though there's something there, and it won't be picked up for 1 or 2 scans down the road because they can't see it until it gets bigger. So know your breast density. So colon cancer is quite preventable if it's caught early. And so essentially, one thing that colon cancer does in our colon is it tends to trickle a little bit of blood in our stool. And that cannot always be visible with our eye. And so it can require a stool test. It's called a fit test. And that should be done every other year for people that are 50 years or above. In many parts of the states, they've lowered that screening to 45 because, just as I mentioned for breast cancer, there's young women are being diagnosed for some reason, still not knowing why, with these aggressive cancers younger. This is exactly what's happening for people with colon cancer. There's a major surge of people developing colon cancer in their 20s and 30s, and it's baffling gastroenterologists because we still don't know what is causing that. And so the stool test detects hidden blood. And then if that happens, if it comes back positive, then people can then get a colonoscopy. And then if there is a precancer or a polyp, they just remove it, and then that's it. If that is not done and the cancer just grows and grows and grows, then it can invade into the deeper layers of the colon and then get into the lymph nodes, and then that's cancer. And that will require a major surgery and often chemotherapy and radiation, which we don't want to have people do if they can avoid it. And then cervical cancer is highly preventable. So this is a cancer primarily caused by a virus, HPV. And so HPV over time can lead to abnormal cells on the cervix. And so screening is recommended at the age of 25 and onwards. It's done every 3 to 5 years. And more recently, our province is switching towards HPV testing, which is an at-home vaginal swab that tests for HPV. The rationale for this is because the vast majority of cervical cancers grow secondary to HPV. So if a person does an HPV swab and it comes back negative, the likelihood of them developing cervical cancer is very low. Whereas if it comes back positive, then we have to keep an eye on that person more so than a person that has no HPV, and they'll have to get a PAP thereafter. And so very important screening to have done. And it applies to anybody with a cervix. Okay. And then the newest screening, this is number 4. We have 4 screenings in BC, is lung cancer screening. So this was really exciting when this came out. It's not for everybody. It's only for people who have a significant risk of who has smoked throughout their lifetime. And so screening starts at the age of 55, and the screening is done with a low dose CT every other year to the lungs. And so this is something that if you know a smoker or if you are a smoker, I would highly recommend getting this screening done, because lung cancer although if it's caught early, if it's still in the lung, they can just resect that cancer and it's curable. Many people who develop lung cancer don't recognize they have lung cancer until they're coughing up blood and they have more symptoms. By that time, it's usually not surgically amenable. And so then we are going to just switch into, well, things that aren't routinely done. So not this, these we're jumping into other scans that you could do that you'd have to pay out of pocket for. They're not covered by our MSP at this time. One would be a full body MRI. So head to toe MRI. And so the benefit of that is you're looking at your whole body, of course. There's no radiation. And you can catch tumors, I put in quotations, early. And then there's always, with everything, there's pros and cons. The con of it is that the reality is that you can catch them early, but these full body MRIs are done without contrast, so they're not as clear as if you had a contrasted MRI. The tumors need to be about a centimeter or larger to show up. Typically, know that if there's a tumor that's a centimeter, it's going to be made up of billions of cancer cells. So it can catch it early, but not as early as one would like. And understandably, these are private scans, and they can be understandably cost prohibitive for people. They're typically over $2,500, but nevertheless, for those that are interested in doing this, it's a very helpful scan, and you should know that it doesn't substitute any of the other screening methods that I've discussed. So it doesn't work as well to assess the breast health as does a mammogram, and one could be surprised by that. And the reason is because uh, MRIs for breast are great screening, but it's not a full body MRI. It's a targeted MRI to the breast, and it requires a specific MRI machine with different coils, and it needs radiation. So just know that this is not to substitute the other screening that we discussed. It would be to supplement for those interested. And so essentially, my takeaway from this is take advantage of what we can screen for, because the vast majority of the cancers that a body can develop, there's absolutely no screening for. So we try to do what we can with our lifestyle and how we live our lives to prevent cancer. We take advantage of the screening that we do have. We know our bodies well. We check more than just our regular blood tests, so that if things are changing in our blood, we catch that early and not wait until things are really off before it's recognized. And so, as I mentioned, when cancer is found early, it's often highly curable with less need for aggressive treatment. And then the last part of our topic, which is just a few more slides, is talking about the genetics of cancer. So there are certainly individuals who carry genetic mutations that put them at a much higher risk of developing cancer. And that is known, and there has been a huge amount of growth in genetic testing as to genes that we know can be linked to cancer. About 5 to 10% of cancers that develop are strongly linked to a hereditary cancer mutation. But interestingly, of people, so if we took a group of 100 people that had one of these strong genetic mutations, but nobody knew that it was, hello, nobody knew that they had a genetic mutation in this group. uh, Only 10% of those people would know that they had a genetic mutation. What I'm trying to say is that we only know 10% of the people who have these genetic mutations. The other 90, we don't know who they are because we don't test for this. So this is where it goes back to, how do you know if you're high risk? Well, in all honesty, most people have no idea their risk because they've never had any genetic testing. And a lot of people will say to me, well, I don't have a family history of cancer. Could I still have a mutation? And the answer is yes, because these mutations develop out of somewhere. And so that person could be the first person in that genetic line to develop it. And if you don't know if you carry one of these mutations, then we can't properly screen for you, because people who carry these genetic mutations, they get enhanced screening. So they're not doing what the average risk people are doing. They get better screening. And so that's what I mentioned here. Significant of individuals who carry a cancer-related genetic mutation are completely unaware of it. 90% of people that can carry these genetic mutations are unaware of it. Only 10% are. That is alarming to me. And so the benefit of genetic testing, again, it's not yet a covered thing in our province or in our country, is if a mutation is identified, you will get early and enhanced screening options, and there could be more preventable strategies considered for you so that it lessens your risk of developing those cancers. And so it's a genetic test that if people had the opportunity to do that, if a mutation was present, I wouldn't want somebody to think that, oh, well, I'm just going to be scared for the rest of my life. That's not the purpose of it. The purpose of it, we can take action. We can get you into an enhanced screening program. We could look at risk prevention strategies that have shown to work for whatever gene that may be. So There's many different genetic panels that can be done. I'm highlighting two of them. So the first genetic panel, so these are hereditary cancer genetic testing panels. So they essentially are either a blood test or a salivary sample, and they look at genes that are known to be linked to cancer to see if you have healthy genes or a mutated one. So the Ambry genetics test is a wonderful genetic test for cancer. It looks at over 70 genes. Its availability, this is the genetic test that is done through the BC Cancer Agency. So they have a hereditary cancer program. So for people that have a first degree family with cancer, or if they've developed their own cancer and they're less than 50, they can be referred to this program and get this test done through their MSP, which is great. The issue with this program is that it's a very small program and there's far more people that need this service that they can accommodate. Um, the other place we have this test at our clinic, but understandably it's not covered through our MSP at my clinic. So I try to see if there's a way to get patients to be covered through the BC Cancer Agency. And if they can, great. If they can't, then I let them know that I can either do the blood sample for them or do a salivary swab. Uh, I don't know of any great genetic test that's based out of Canada for cancer. So it's USA. And as I mentioned, Ambry is salivary or blood. And then another genetic test, which is great, all cancer, is called Color Health. It doesn't look at nearly as many genes, but it still looks at plenty. It looks at 30 genes, very easily accessible. If you just look up Color Health Genetics, you can order the kit over the internet. Super easy that way. It's again based out of USA and it's a salivary sample. And then the next slide is just to show you what it can look like. So this is a color genetic test. And so these are all the genes that are checked. So there's 30 of them under the cancer column. And then it'll tell you let's say, so I see a lot of patients who have BRCA mutations. I see a lot of patients who carry Lynch syndrome, which is these MSH2 and MSH6 gene mutations. And so if somebody has one of these mutations, we can see, well, what cancer are you at a higher risk of developing? And if we know that, then you could do screening, such as for ovarian cancer, or such as a transvaginal ultrasound annually, where there's no screening for ovarian cancer for average risk people, but there is for people who carry these genetic mutations. So that's just an example. I'm back. I don't know what happened. Hopefully you guys can see me. Can you see me? Thumbs up if you can. Okay. And so essentially, you don't prevent cancer one type at a time. You reduce your risk by changing the environment in which it develops. So how you're eating, how you're sleeping, how you mitigate your stress. And although we work hard to be healthy, we have to recognize that we certainly cannot prevent all cancers. And that's where we take advantage of what we can screen for, and we get to know our bodies well. And if something's not feeling well, we seek help for that. And so now what I'm going to do is I'm going to open um, the conversation for questions. So there's a little chat box at the bottom of your Zoom. And if you've got any questions, you can certainly write them out there. And then we could spend the next 10 minutes or so answering any questions that may have come up for this presentation. I'll give a few minutes for people to write in questions.
There are a few questions there already to Dr. Rurak.
Oh, I can't see them. I wonder, maybe if you have a question, it might have gone away because my Zoom closed for some reason. Maybe you could type it again, or if you wanted to unmute yourself, that would be fine too. Are there any specific brands of sunscreen that you recommend? Yes, there is. It's called La Roche-Posay. Oh, perhaps I should be asking this question before. So are we asking about sunscreens that are available here in North America? Or are we asking about sunscreens that you can get in Europe and Australia? For here in North America, any type of sunscreen. Pardon?
I was just going to say, my question was like in Europe or any place, just what would be the best one that you would recommend? Thank you.
Yes, it's La Roche-Posay. So I'll try to find it. Posay sunscreen with Tinosorb. Yeah, I'll copy and paste or see if I can put this into the notes here. So that one is great because it has the Tinosorb in it. But again, what's quite interesting about this is that the La Roche-Posay is very smart. So they make the sunscreen bottle the exact same as what you get in Europe when it has the Tinosorb and UVA protectors in it as what you get in North America. So you think that you're getting it with the same ingredients, but it's not. But La Roche-Posay, if you go to London or Europe and you get those ones, they will have the UVA protection, but not if you buy them here in Canada, even though they look the exact same, the bottles. So efficacy of blood tests. So efficacy of blood tests essentially for picking up cancer. Well, there's not a so it depends. We didn't talk specifically about what blood tests could be used to pick up cancer, but there are blood tests. They're called circulating tumor cell tests. And so they look for DNA cell fragments from cancer that float around our bloodstream, and it's a blood test. And then I just did one this morning. So the blood is pulled for a patient, not myself. And then that blood has to be shipped to Germany within 2 days. When it gets to Germany, they look for the CTCs and they can quantify the number of CTCs in that blood. And then those reports come back. And that can be done annually or whenever we want to see if there's any increase in the number of CTCs. I generally only do these labs for people who have had a diagnosis of cancer. They don't have cancer, they're in remission. And we're doing this to make sure that their CTCs stay low. And I only do it. So that group of people. And then some cancers produce tumor markers. So if a person had a cancer, when they have the cancer, I check all the tumor markers to see if that cancer makes a tumor marker, which is an easy blood test that we do at Life Labs. If there's no tumor marker that we can track in that person's blood, then I would suggest that we consider a test such as the CTCs. But this is not something that I would generally do for people that have had no history of their own personal cancer. And they're quite effective. Drugs for arthritis suppress the immune system. So it depends. So yes, so there's a lot of medications that can actually increase one's risk of cancer. And usually how they do that is their action suppressing the immune system. So examples would be any type of steroid that's used for, 3 months or greater has the potential of increasing one's risk of cancer. Drugs, usually drugs for, let's say, osteoarthritis, no, because there's no immune suppression in that. Usually it's an anti-inflammatory. So anti-inflammatories don't suppress our immune system, they suppress the inflammation. But if people, let's say, have rheumatoid arthritis, or if they have colitis and they're on biologics that suppress their immune system to manage their autoimmune condition, then for sure, those are well-known drugs that increase one's risk of cancer. So the cost of the test done at the clinic. So the cost of the Ambry genetic test, so that's the 70 plus gene panel test. That's a once in a lifetime test because your genes don't change typically. That one I think is about $1,000 Canadian. If you compare that to the color test, which assesses 30 genes, so significantly less, but it's still a really good option. That test, you don't need to do it through this clinic. You can do it online through the color. I believe that is 300 American. So if you think about it in terms of the amount of genes covered, it's very similar per gene cost. Is there a relationship between regular supplement use and cancer? Not at this time. I could not say that there is X supplement that if you take every day of your life will reduce your risk of cancer. The closest I could come to that, just for global, is vitamin D, because we know that a vitamin D deficiency can increase one's risk of cancer. So if you supplement with vitamin D, then that may help reduce one's risk of cancer. But other than that, there's not a one supplement that would work for everybody to lower one's risk of cancer. So what about, so a question was, you mentioned that cancer developing in a suppressed immune system, but what about an overactive immune system, such as in an autoimmune condition? So in an autoimmune condition, so rheumatoid arthritis, colitis, those are considered autoimmune conditions. And it's true that it goes both ways. So if a person, let's just use colitis as a good example. So that's an autoimmune condition of the gut. If somebody has colitis and it's uncontrolled, then they're getting exposed to this chronic inflammation in their gut because for some reason their immune system is recognizing their colon cells as foreign and it's attacking it. That chronic inflammation in their gut increases the risk of cancer. So yes, uncontrolled autoimmune conditions can increase the risk of certain cancers. But the conventional methods that manage autoimmune conditions are typically, they have immunosuppressive activities. They suppress the immune system, so the immune system is no longer attacking itself, but it does a blanket suppression. So it also suppresses our immune system that should recognize a virus, a bacteria, or our own cells that go haywire. That's why people that are being treated with their biologics to manage their autoimmune conditions are at higher risk of colds and flus and of cancer. Is there something that you can do to have is there something you can do if you have HPV to prevent it from becoming cancer? Well, yes, we want to keep that HPV in a dormant stage. So HPV is a virus that is what causes 98% of all cervical cancers, but there are cervical cancers that develop without HPV. We cannot forget that. And so the best way to help that body not develop cervical cancer is to work to get that HPV into a dormant stage so that it's not active and it's not causing any issue. To do that, we work with your immune system. We try to figure out how we bump it up. Sometimes transvaginal vitamin A can work really well to get HPV from active to dormant. Even I use this quite frequently, is escharotic treatments, which is a topical treatment to the cervix for low-grade abnormal cells on the cervix. It can preferentially just kind of target those abnormal cells on the cervix. I do that along with an anti-HPV protocol so that we're lowering the HPV and trying to slough off those abnormal cells. And it works beautifully for low-grade abnormal cells. Well, it's 7:33. I know there's a few more questions, but don't ever hesitate to contact our clinic with a question. I'll do my best to answer it. And it's so lovely having all you on the video. And for those that are my patients, I'll see you sometime in the future. And for those that are just watching, I hope you enjoyed the webinar. Take care, everybody. Have a good evening. Bye-bye.